brain tumors. All of us are afraid of function of the brain. When it is affected, our day-to-day life gets affected. The entire family gets affected. These tumors can happen at any part of the brain, at any region of the skull. It can even go onto the nose, it can go even into the ear, it can go into the spine. Depends on where it originates and how it spreads, the symptoms will differ. Hi friends, this is Dr. VIKRAM, Head of the Department, Senior Consultant Neurosurgeon, Minimally Invasive Brain and Spine Surgery, Ramakrishna Hospital, Coimbatore. Let us speak about brain tumors. All of us are afraid of function of the brain. When it is affected, our day-to-day life gets affected. The entire family gets affected. So, one of the reasons where the brain function can affect is brain tumor. So what as such is this brain tumor? Any tumor which is involving the skull, the covering of the brain, what we call dura, or as such the brain per se, is called brain tumor. Our brain is made of lot of neurons and support structures called glial cells. Glial cells are like connecting tissues which bridges each brain cells with each other. And these tumors can happen at any part of the brain, at any region of the skull. It can even go onto the nose, it can go even into the ear, it can go into the spine. Depends on where it originates and how it spreads, the symptoms will differ. We all know we have our brain, this is called the frontal lobe of the brain, the parietal lobe of the brain, the occipital lobe of the brain, the temporal lobe of the brain. Our highly evolved emotional functions are part of our frontal lobe. Our motor activity, that is our movements, are controlled by the frontal lobe, and our sensations, understandings are all controlled by the parietal lobe. The vision is controlled by the occipital lobe, and memory and music, all these understandings are controlled by the temporal lobe. And there is structure called thalamus, that's again an interior part of the brain, which is a sensory relay of our brain. And the main part of the brain, what is called brainstem, which controls our sleep cycle, blood pressure, heart rate, our vomiting sensation, positional sensation, and lot more are controlled from this brainstem. Apart from that, our smooth movements are controlled by these two structures, what we call as cerebellum. So the right side of the brain controls the left side, and the left side of the brain controls our movements of the body and sensations on the right side, including the speech. So this skull, the bony part of the head, has multiple ups and downs, depends on where and which part of the brain it is situated. And this is covered by a layer of thick tissue, what we call as dura, within which there is a fluid filled cavity within the skull, in which the brain is floating. Basically, the brain is very soft and fatty structure. It needs to be floated. Otherwise, with all so much of movements, the brain will have lot of damages. So God has created such a wonderful environment for the brain to get floated, buoyancy, and protected. We have two rooms within the brain, what we call ventricles, where the CSF, that is the fluid from the brain, gets into one another small room called third ventricle, and from there within the cerebellum there is one more small room called fourth ventricle. the CSF, that fluid of the brain, flows through all this, comes out, goes up around the skull and get absorbed. So any abnormal growth, whether it is from this thick layer around the skull or within this brain or within this ventricles, all considered as tumors. The tumors can be benign, which is less fast growing. It may take 10 years, 15 years, something like that to grow, which may not directly affect the brain, but because of its location, it can cause either a pressure effect or a convulsions, or because of the location, the functionality of the brain can get affected. At the same time, there are fast growing tumors which happens within the brain or even from the blood surrounding the blood vessels of the brain, which can cause a rapid growth, which is a malignancy of the brain, can affect the brain. So though both the diseases have different pattern of growth, the symptoms many a time will be because of the functionality or because of the pressure by headache or by the abnormal electrical activity by convulsions, any of this, or facial weakness or swallowing difficulty, difficulty to walk, difficulty to balance, depends on where and which part of the brain, as we discussed before, it can present to us. So the most common will be headache, vomiting, abnormal movements or decreased movements. So once we know some of the features which is affecting them, we get a CT scan or MRI scan to see where exactly the problem and how it is causing. Though we can clinically assess this is what is happening by the patient's symptoms and what he has problems like, we will be more sure and more defined about the problem when we get the MRI scan. So once the scan is done, we know what to do. So if it is a benign tumor and if it is affecting the brain because of the mass effect, we just have to open a small portion of the bone around that abnormal growth. With all the present technology of CT guided, MRI guided navigation, we focus exactly where the problem is and open only that portion of the skull, and we can go in, define what the problem is, and there are technologies like fluorescence guidance, ALA chemical guidance, where the abnormal growth will be visualized in different color and the normal tissue is different color in what we use as a operating microscope to magnify the location where we are operating with all our micro instruments. So this will help us to protect all the normal part of the brain and remove only the abnormal portion, whether it is outside the brain or whether it is from within the brain. This will help us to protect the normal part of the brain, have less problems to the patient and recover them much better, and with small incisions and small opening, depends on the size of the tumor, we will be able to get the tumor out. So once the tumor is out, we, with all our present technologies in molecular genetics and immunohistochemistries, we know what is the nature of the tumor. When the tumor has less growing potential, then practically once we remove the tumor, patient is close to cure. The chance of it growing back will be very less. And when the tumor is little bit fast growing, we have other technologies where like radiotherapy, chemotherapy, these will help to reduce the recurrence or the regrowth of the tumor as much as possible. At times definitely some malignancies are not definitely curable. We can only give the quality of life till the tumor takes over them completely. But majority of the tumors which we can treat with benign tumors, completely removable, and where there is chemo and radio, which they are very good for chemo and radiotherapy, they have a reasonable quality of life and quantum of life. Where comes the minimal access brain surgery? If the tumor is within the room of the CSF, that is what we call ventricles. We can use endoscopes, take the endoscope inside the brain into these water chambers, identify the tumor, something like colloid cyst, central neurocytoma, or certain diseases where we can take the endoscope into the brain, locate the tumor, remove it completely by endoscope. And certain tumors, when they are deep inside the brain, at the same time we will not be able to visualize completely. Again, after opening the skull, we take the endoscope inside and see the portion which we are not able to see directly in open microscopic methods and remove all that. So these are possible with small minimal access brain surgery with endoscope and microscope. There are tumors which comes down right into the nose through the skull opening. Again, through the nose itself, we can take the endoscope, open up the tumor area and remove the entire tumor completely by endoscopic guidance. The same way, when there is some tumor which is behind the ears and into the skull, we can open up the bone behind the ear in a small portion, use the endoscope, go in and remove the tumor completely even with endoscope. All depends on what kind of tumor and from which part of the brain it is coming and how much it is accessible with our microscopic or endoscopic techniques. 90 to 95% of the tumors are safely resectable. There are recent advancement where the tumor is happening from the main motor area of the brain, what we called as awake craniotomy with intraoperative neuromonitoring and cortical mapping, where the patient is kept awake. We operate with sufficient painkillers given around the skull so that patient doesn't feel the pain. We allow them to sleep in the initial stages of the surgery, and once we open the skull, open the dura, that is the protecting layer of the brain, we allow them to come around and we start localizing which area controls their speech, which area controls their movements of the limb, define it with stimulations. After that, we will identify the tumor, how much far away it is from the lesion, and even if it is close, if it is not involved, then we will be able to remove all that tumorous portion with the cooperation of the patient and frequent assessment of the patient, how they are moving their limbs or respond to our commands, how they are able to think, speak, listen to music. All the brain functions can be assessed by one of our colleagues who will be coordinating with the patient, and we will be able to remove the tumor to the maximum extent with the portion. If it is involved by any of these functions, we will leave that small portions. Again, during this procedure, we will use what we call ALA or a fluorescent guidance, where the tumor is distinguishedly seen compared to the normal brain. So, using multi-modal treatment with a minimal access, and even sometimes we use what we call ultrasound machine in the theatre, where we can define which part of the brain is affected with the tumor and which part is not affected. So, multi-modality minimal access is the main concept of minimal access brain and spine surgery. Here the opening is small, we have multiple technologies to use to define what exactly we are handling with, and with less deficits we will be able to remove the tumor whatever it is. It may be benign, it may be malignant. At the same time, finally the technological analysis of the tumor will at molecular level, genetical level, helps us to identify which will recur more, which will not, which will respond more, and we have to follow the treatment. Gone are the days where the quality of life is compromised. With all these technologies, we will be able to give you a reasonable, good quantum and quality of life, which is what is mainly on minimal access brain surgery. Thank you.